Good afternoon or evening. Welcome to CPT webinar number 6. As you folks recall, we had some technical difficulties with the neuropsych section of the CPT webinar series, and we needed to redo them, partially because of the technical difficulties, but also because some different pieces of information have actually surfaced since our last time together. I also want to let you know that this is the last of the CPT webinars. I will probably do one on ICD at the beginning of the calendar year as we have that all flushed out. But for now, we are going to wrap it up, among other things. We have other things to attend to. And also, finally, before we get ball rolling, I want to thank you guys for all the kind words and congratulatory comments that you have sent. I look forward to being able to respond to you in the very near future. For now, we'll go ahead and begin to do our screen share. Okay. Here we go. So here we are. So let's go ahead and begin, as we always do, with the basics, and that is there you go. I apologize. One more step. There. I apologize for this minor problem, but anyway, this is the typical disclaimer that I have. Certainly nothing new. I'm doing the best I can, but I can't guarantee this information is entirely correct. So, as always, many individuals and organizations have been very supportive. I want to particularly emphasize the American Psychological Association, as well as the American Medical Association, and finally, the Center for Medicare and Medicaid Services. They really have been very supportive of this work, and they need to be acknowledged. Many individuals, including Neil Pliskin, Randy Phelps, and Jim Georgialakis, have all been very, very active in this process for a long time. The staff of AMA, including the primary person there, Marie Mindenman, has been very supportive of this work as well. So thanks to all those people. And for those of you always wondering, I suppose this is the economic support. I do not get support from the American Medical Association economically, although they pay for all the expenses. And the same applies to the American Psychological Association when I represented them. I am on the AMA CPT panel, but this information does not represent that, or it's not associated with any economic reimbursements. All right, so I've been doing this since probably 1988. Got really heavy with it back in the early 1990s when I was appointed by APA to represent them, or us, I should say, in the CPT process when they opened up to non-physicians. And subsequent to that, I was elected to the actual panel about 6 years ago. 7 years, and that service will continue through the end of, or actually, to be honest, I think through June of 2016. Now, everything that we talk about should not suggest or indicate any difference between what we have to say in APA Code of Ethics, your licensing requirements, and in many ways, most importantly, the contractual agreement that you have with your insurance company. Make sure you're aware of those. We'll talk about that in a few minutes. And this is specifically what I want to mention. You need to become familiar with a local coverage determination. They vary significantly. We've actually done some research on the Medicare, and the amount of variance between Medicare carriers is unbelievably large. Imagine how that applies to private carriers as well. As a rule of thumb, the individuals who come up with LCDs are essentially going to do a slight variation, very often more restrictive variation of what I'm going to talk about, and that's national policy. You need to understand that you are responsible for all the contractual agreements, whether they're stated in the contract or posted in a website or elsewhere. So be careful. You need to abide by these rules. All right, and finally, in terms of introductory material, this is copyrighted material from the American Medical Association, despite the fact that this is actually owned by CMS. It is copyrighted by the AMA. So a couple of quick things. I want to make sure you understand. You are essentially a qualified health professional. That is, an individual who has the actual contract and is independently licensed to practice. As a rule, this does not include master's level associates. A technician, in contrast, is anybody else. It doesn't matter if they have a high school degree or, for that matter, a postdoctoral fellowship and are licensed. Very simply, if there's no contract, they're not the qualified health professional. This is a slide that's meant to be savored and not necessarily read. This gives you an idea when we started the coding proposal process for the testing codes, which we're talking about today, and they continue as we speak. And I'll explain where we're headed in the very near future. For now, I'm going to introduce for some and go over several pieces of basic information as they apply to the CPT codes. First of all, is the concept of what we call a base code. Base code is the foundation for other codes. For example, if we were to do a open heart surgery, the open heart would be the base code, and then anytime that we add something to that base code, for example, each bypass, that would be an add-on code. Again, the basis of fundamental foundation. The add-on is anything that's extra to, once more, the base code. We'll talk about that a little bit today. And finally, you shift the code from one code to another when a significant disruption of service occurs. That is, that you would not return the original service, and for that matter, the new service is quite different than the original one that was performed previously. With all this introduction, let's begin to jump into the specific codes, and we are going to focus on one of the three that we have here, and that's basically the neuropsychological, or what it's often referred to as the CNS, Central Nervous System codes, which were introduced in the late 1990s and have been refined over time over the last several years and will be refined even more. So with that, let's jump into the fray. The CNS assessment codes, which as you can see are outlined in two articles, the CPT Assistant from the American Medical Association, which I helped co-write at that time, includes the Neurobehavioral Status Exam and the Neuropsychological testing codes. We're going to focus on the neurobehavioral status for a short bit, and then the neuropsychological testing for a long bit. All right, so basically, for the testing codes, a minimum of 31 minutes must occur for an event to be registrable. If you do not have 31 minutes, you do not have a unit. These services are billed in increments of 1 unit, and 1 unit equals 60 minutes, and 31 minutes is the minimum that is required for that activity to occur. Let's focus for the next little bit on the neurobehavioral status exam, which, as you can see, was implemented in 2008 and has undergone some minor revisions here and there. This code is 96116, and as you can see, is a clinical assessment of thinking, reasoning, and judgment. I want to emphasize some words here. First of all, clinical. Clinical means not quantitative. This is qualitative data. However, you are welcome to do a small test as long as, for example, the MOCA or the mini mental status, as long as that is not the preponderant activity during this code. Number one. Number two, that we're talking about per hour. So you could bill more than 1 hour. And number three, and maybe most important for many of us, is both face-to-face time, that is interviewing the patient, and interpreting test results as well as preparing a report. So it could very well be that the total number of minutes in which one person or a professional actually works with a client may be less than the total time spent in interviewing others, interpreting test material, and preparing the report. A neurobehavioral exam is completed prior to the administration of a neuropsychological test. This comes from a CPT assistant, and for what it's worth, the status exams again involves the clinical assessment, including collateral interviews, and it could be limited but expanded from thinking, reasoning, judgment, including acquired knowledge, attention, language, memory, planning, problem solving, and visual spatial abilities. The clinical assessment is the base code in which you would proceed to do an add-on code, which will be testing, and we'll discuss that in a few minutes. Neuropsychological testing by professional. You remember what we said earlier, that by professional means by the individual who is independently licensed to practice psychology in their state or territory, and that individual would also be in a position to have a contractual relationship with the payer. So for example, I have a PhD, I'm licensed in North Carolina, and I have a contract with Blue Cross Blue Shield of North Carolina. As a consequence, I am the person that could use this code, 96118. I'm sure you've noticed, if not, I'll point out to you, that just about all the descriptors that I had anything to do with are all EGs rather than IE. So these are some of the types of tests that you might administer during the 96118 encounter. And as we said with the 96116, this is face-to-face, administering the test and interpreting these test results. However, 1.8 is also used in those circumstances where the additional time is necessary to integrate other sources of clinical data, including previously completed and reported technician and computer administered tests. However, do not report 1.8 for the interpretation and report of the singular versions of 1.9, which I'll get into. So essentially, and we'll go into some detail, this is used for your work as independently licensed psychologist with a contract with this insurance company to select the test, administer the test, score the test, interpret the test, do a report, as well as a follow-up. This is the code of choice for follow-up, unless, of course, the LCD or your particular carrier tells you otherwise. So this is the code that's reported for neuropsychological tests, in other words, quantitative information, and as you can see here, subsequent interpretation. It is reported for the integration of information obtained from other sources, which is then incorporated in the more comprehensive interpretation of the meaning of test results. This is for the purposes of a physical health diagnosis. And we'll talk about diagnosis in a few minutes. 1.8 would be, as I said earlier, the scoring, administration, and so forth, as well as the integration of those findings in the final report. Let's talk about a technician. That is 96119. This is, again, the administration of these tests by essentially a technician. This is a technician who's doing this. It's important, extremely important, to understand that this has to do with a face-to-face encounter of the individual and does not include non-face-to-face activities such as scoring. The qualified health professional has previously gathered information from the patient about the nature, and based on the history and other things, a selection of tests is made by the professional. The procedures are explained to the patient, and the patient is introduced to the technician who then administers the test. The professional checks with the technician and monitors the performance. When all tests have been administered, the qualified health professional meets with the patient to answer any questions. This is a code that's relatively different than maybe some of us have anticipated, and that is 96120, the Neuropsychological Testing Code, by computer. By computer. This is intended to be a very different. This is not computer assisted. For example, in some ways, I think the Wisconsin card sorting test is not an appropriate choice. Maybe something like the MMPI or maybe CNSVS, something where the client comes in, the secretary, not the technician, not the professional, puts the person in front of the computer, gives them the instruction, they work on it without supervision. At the end, you press a button and out comes a report. That report may be integrated with other things, but there is no cognitive component. There is no cognitive component because the professional's not there, and for that matter, neither is the technician. It is reported for the computer administered, and I apologize for that typo. This should be reserved for situations when the computerized testing is unassisted. Unassisted. Now, something that people don't understand, computerized testing is not time-based. It's once per testing session to be used for one to multiple tests only, once. So it's not like you can administer multiple tests and do several units of this. The most units you can use for computerized testing is one, and it's not time-based. You might be surprised that neurologists tend to be the largest segment of individuals using this particular code. And because of this very unusual use by neurologists and the fact that it's increased in percentage usage up to about several 100% every year, 300–400%, we have actually tackled this issue, and we will address it in a moment. Keep in mind that it's not unusual to have a technician and a computer, as well as a professional, being involved in the administration of the test. All of the testing assessment services also require interpretation. That's where the 1-8 comes in. The interpretation is done by the professional who has independent licensure in their state or territory and who has a contractual arrangement with the insurance carrier. And as you can see, the neurobehavioral status exam and the neuropsychological testing are administered one per illness condition or when a significant change in behavior occurs. So for example, somebody has dementia or multiple sclerosis. Theoretically, you can only administer once during the entire dementia or multiple sclerosis. However, there are times where things change. And when things change, it's time to get back in the saddle and redo the evaluation. To address the concerns that we have mentioned before, and that is that a large number of non-psychologists are actually using the computerized testing code, we've actually come up with one that is a screening testing code, 96127. I want to emphasize that this is essentially an add-on code primarily for physicians as an add-on to evaluation and management. So essentially, these codes have to do with the evaluation and management extension of services. You might wonder for a little bit here, how much are we getting paid? Well, take a look at 96116, that's reimbursed at $94 an hour, and 96118 at $99, and 19 at $81, and 120. Remember, this is a one-time per evaluation at $48. So typically, an evaluation might include maybe 1, 2, 3 units of this, maybe 1, 2, 3, 4 units of this, maybe several units of this, 5 or 6, and then possibly a 120. if you want to address the big, never-ending question of can you use 1.8 and 1.9 together, the answer is found in a number of locations. But let me point out to you this particular CMS, I would like to say is transmittable explanation. Now, what is this explanation all about? First of all, local LCD trumps national policy. So whatever I tell you may or may not be applicable to the contractual arrangement that you have. However, some will say you can't ever do this together. Another one says no difficulties. And we're going to talk a lot about alternatives, including the use of 59 as a modifier, and that is when the professional and technical codes are used simultaneously. And by that I mean on the same day, not necessarily at the same time. So let's go into the discussion by Niles Rosen, the director of the National Correct Coding Institute, and where we've had discussions over a number of years. And let me outline this for you. When the provider administers at least one test, then the two testing problems do not apply. So one way to get rid of the problem is for you to administer one test. Which one is up to you. When the professional and technical services are not provided on the same day. So for example, I have the neuropsych testing by technician on Thursday, and I do the report on Friday. That are the two simple ways to look at this. Two or more codes may be reported on the same date of service if and only if the different testing techniques are utilized for different neuropsychological tests. 96118 and 19 can be reported on the same day if the professional personally administers at least one test to the patient. Now, why could this be the case? Well, when services are provided together, there has to be empirical evidence suggesting increased efficiency, but also we have increased costs. And there's a big issue with the fact that when these two codes occur, they do so in high volume, and it turns out to be a problem for CMS. Some insurance may be excluding the use of both of these codes, and some edit systems like Ingenix may be disallowing these codes. The biggest problem, it turns out to be, is the compliance officers or large institutions that in the September 2006 transmittal from CMS says that these codes should appear together only in rare circumstances. Rare circumstances. We have worked very diligently to explain that it's not rare, it's actually common. So one way to go about doing is if you consider doing the test on the same day, consider using 59 to the 19 code. Although it could be applied to the 18, it seems to us and CMS that the best alternative is to apply it to the technician code. Now let's go into detail because Emory University, and specifically working together with Epilepsy Foundation, has some questions. And the question, for example, can you integrate separate reports and tests performed by a technician into a comprehensive? And they have several questions answered. Our answer is yes. If several different clinically appropriate tests are administered on the same day to the same patient, then the appropriate testing codes can be billed together. And more than one code can also be billed when several distinct tests are administered to the same patient on the same day. Additionally, the AMA provides further guidance for CPT billing, and the descriptors of CPT 101 and 18 and the parentheticals that follow these codes provide further instructions how you can use these codes when additional time is necessary to integrate separate interpretations of the comprehensive report. Another issue is, can neuropsychologists integrate separate report of tests performed by a technician? Again, the answer is yes. When the technician administers the test and bills the amount of time it took to do 119, may the time spent by the psychologist interpreter in writing the report of those tests be added to the time? No. And the reason for that is because that is not a technical service. What you have to do is bill it as 1/8. What's the takeaway message? Bill for what the techs do, period. Number 2, bill what the professionals do, period. And you can bill both of those sets of codes together. You just have to be careful of how you go about doing it. 2-code summary. If 2 testing codes are used on the same day, professionals should perform at least 1 test, or alternatively, 1 activity should be done on one day, and another activity should be done on another day. A quick comment on the use of psychiatric interview and neurobehavioral status exam. You should not use a psychiatric interview or 90781 on the same day as 96116. In fact, I've gone on record on numerous occasions, and I said this earlier tonight, that the interview for neuropsychological situations is not 90791, it is 96116. I also want to emphasize that if your particular policy says you should do 90791 as the interview, so be it. You have to abide by the contractual arrangements that you've chosen to sign on to. So, what would a typical evaluation look like? It would be an interview by the professional, and then followed by testing by the professional, by the technician, and or the computer. The interpretation would be done by the professional. A technician code is quite different than the professional code. And I want to say a few words about this. As much as we want to make sure that our students learn how to do reports, or as good as our technicians might be, the report must be written. The interpretation must occur by the professional, not the technician. They are not being paid by the carrier. You are. So here's some interesting statistics. This came up with these recently, and here they are for 118, where it's occurring over 500,000 for the 2014 Medicare, and psych testing by technician, neuropsych testing, is much lower at 147, and 96120, 24,000. A couple of comments regarding this. I'm surprised by the discrepancy between 19 and 571,000 for 18, largely because approximately about half of us who do neuropsych testing use technicians, but clearly the large number happens to be 18. If you look at some of the important practice surveys, such as the ones that Jerry Sweet and colleagues have published, these would lead me to believe that these numbers would actually be reversed, but indeed they're not. All right, here's an idea. I'll float this idea, which is very different. Some of the tests that we use are extremely expensive. Might we want to consider using a HCPC code, which is an add-on code? None of us have ever done this, but this happens, for example, when you do plastic surgery. There's certain kinds of skin that are much more expensive than others, and when that happens, it's not atypical for the surgeon to charge for that skin under what we call the HCPC codes. This is something we may want to consider as a specialty, that maybe in the future, as some of these tests become beyond the value that have been agreed to in our practice surveys, maybe we need to reconsider establishing a HCPC code list for some of these more expensive tests. What's coming down the pike? The applied behavior analysis obviously is a big issue. APA and Neil Pliskin and Randy Phelps have been tackling the issue of test screening and test feedback. We've got a long ways to go. And of course, the development of integrative care codes, which includes, among other things, the possibility of coordinated care, prolonged care, and so forth, so on. These codes are all associated with the development of ACA and the idea that we no longer can or will be able to practice in silo situations. Our reports, our services will have to be integrated into a larger ACO, Affordable Care or Accountable Care Organization. And when that happens, this will have to occur. At the present time, there are no adequate CPT codes to envision what we need, but this is the beginning of a big, big change for us. So let me turn my attention, or our attention, to diagnosing. For those of you who have had the opportunity to listen to some of my ICD-10 workshops, you're welcome to take a look at that, and for that matter, to find a more comprehensive analysis of my interpretation of ICD-10, specifically CM, in my website, psychologycoding.com. But for now, let me emphasize some of the big things. First, the billing diagnosis is what you go after. That is what you put on the insurance form. It may not be, or may be, the same as a clinical diagnosis. Keep in mind that the billing is what you go after. The clinical diagnosis is what you find. It could be the same. It could be different. This is something that Jennifer Morgan from Virginia has emphasized over many years with her work as a neuropsychologist as well as an insurance consultant. They may be the same. They may not be. But insurance companies will not pay you to do 10 hours of testing if you find out that the person is depressed. If you put depressed and 10 hours of testing, your EOB will reflect a negative response. Essentially, we have historically been involved with ICD-9 clinical modification since 1978, and effective October 1 of this year, we're now going into the world of International Classification of Diseases 10-CM. I want to point out something. Even though it's called International Classification of Diseases, I think it's best to call this International Classification of Disorders, because if you look at the 10-CM, the way to look at things is not by disease process, but by symptoms. And diagnosis in the old days would have been like 382.9, and now becomes B01.2. A procedure like 39.5 might look like OD and so forth. This is the new world that we live in. For those of you who have studied this and you find it repulsive because of words like mental retardation and neurosis, I appreciate the fact that this system, ICD-10-CM, was released in 1990. So we are actually thinking that this information is very, very old-fashioned and includes things that have gone out of style. The word organic, neurotic, and mental retardation are part of the ICD-10-CM and not what we consider to be acceptable for this day and age. You have level 1 is alpha, level 2 is numeric, and level 3 to 7 will be alpha and numeric. So a diagnosis might look like that. Now, let's talk about this for a little bit. First of all, I have a very long slide set in the Psychology Coding website that you're welcome to download. It's sure to cure any form of insomnia. The other thing that's important is I don't know how people are interpreting this, the carriers, that is. I've been told by 2 major carriers that the rejection rate because of ICD-10 diagnosis, it's extremely low. It seems to be, according to one, namely Optum, about 2%. So my initial impression is that most carriers are accepting just about what you're putting in. However, I do have serious concerns about this particular issue. First of all, the DSM is not a diagnostic system. It's basically a portion of the ICD that was lifted, that is the numbers, and you have a description. So the DSM is a descriptive system, not a diagnostic system. ICD is the diagnostic system. And for neuropsychologists and to a degree health psychologists, I have major concerns because most of us in psychology are going to be living in chapter 5, or what I'm calling the F codes. In this particular case, we as neuropsychologists will probably live outside of chapter 5 or outside of the F codes. So you might, for example, have a R, S, or G codes. In the Wordsworth category, I've actually done two things. First, I've actually built a series of small number of claims with both F codes, psychiatric codes, as well as non-psychiatric, or if you will, medical codes, for example, epilepsy and so forth, so on. And we have gotten reimbursement from all carriers at this point. The other thing is that we're working on, as we speak, is a system to do a Dropbox where people can populate information regarding their experiences with ICD codes versus CPT codes. We have the system worked out. We're going to do a dry run with the folks at NAN. If folks from Division 40 practice would like to participate, we'd like to extend that to them as well. And then we'll put this in a public domain, and hopefully people can populate and search as they need. Because if we have on one hand CPT codes and on the other hand we have ICD codes, that entire system, or if you will, the diagnostic column, has been erased. We're in many ways having to start over to try and figure out what diagnostic codes go with what CPT codes. It's a new world. So a few words. Medical necessity. What is medical necessity? It's essentially what I just told you. It's a combination of what CPT codes are populated or can service what diagnostic codes. So it makes sense to me that someone that has very refractory, very complex depression might benefit from neuropsychological evaluation. However, if you give somebody with depression a CPT code of 96116 or 118, you will get denied because that's not appropriate. Now, if it's a memory problem secondary to depression, that's entirely acceptable. So what we're looking for is establishing a CPT by DX formulary, at least very generic with each insurance company. You may want to consider trying this on yourself, or as you find certain codes that seem to fly with insurance carriers, consider posting them in different listservs that you happen to participate. Now, the biggest problem in terms of fraud and abuse turns out these days to be poor documentation. So a couple of minutes on what may be appropriate documentation for any kind of testing activity. First of all, identifying information, the patient, Social Security, last four of their Social Security, right-handed, left-handed, whatever. Reason for service. Where does the referral come from? What are you trying to do? The dates and the time. The days of elapsed time are pretty much behind us. We are now dealing with actual time, and that includes time started and time stopped. We can't do that very well in the report with all the different tests that we administer. So what we do is we actually do it on the actual testing face sheet. You may want to consider the identity of a tester or a technician. I happen not to, but some other individuals do. It seems like a wise idea. Test protocols involve the actual additions. Don't put ways, put ways 4 or 3. Narrative results. This is actually what you discovered, the diagnosis and disposition. It's important that you consider disposition, and for that matter, that you consider diagnoses. If you look at my ICD-10 workshop material or the slide set, one of the things that I emphasize is the importance of multiple diagnoses. The days of singular diagnosis have come and gone. So we're now moving into a different situation. And what you need to do there is include all the diagnoses that you have actually read in the medical record. So if in the medical record you have discovered COPD, diabetes, and chronic pain, those have to be added. However, you need to start with the most important diagnosis first, and then you drop down in level of importance as it goes from most important to least important. A little side issue here. If the patient says, I have diabetes, but there is no record that says they have diabetes, you can't do it. Let's take even one that's even more interesting, maybe more obvious, because diabetes is hard to see. Let's take someone that walks into the office to do an evaluation that weighs 350 pounds. You want to consider that diagnosis will be obesity. However, you have no record from a medical provider that there is obesity. You can put that information in the history, but you cannot put self-reported information in the diagnosis, because that would essentially mean that you'd be the first provider to diagnose something, and that would be outside your scope of practice. You are not trained to measure obesity. You are trained to measure cognitive and emotional problems. So what might this assessment information look like? Of course, you have individual tests. You might want to have some numerical tables and some basic qualitative. In my case, I actually put numerical information in a table, and I put very little qualitative data in the actual report. The professional component is what you actually do to integrate the history, prior records, interview, and all the tests that have been administered by you or someone else. When this happens, you generate a report. Each CPT code should generate a separate report, or at least a separate section within a report. So you may want to have a section called Neurobehavioral Status Exam, another section called Neuropsychological Testing by Technician, and if appropriate, Neuropsychological Testing by Professional. Label, title, the sections to match, the actual code descriptors. Some people I know actually put the numbers as well as the narrative label on each of the sections. Now, let's move our attention for a few moments on time. You can do both face-to-face and non-face-to-face. However, it just depends. You can do this for therapy. You cannot do this for, if you will, technical codes, but you can do this for professional code. Time is face-to-face unless otherwise. Keep in mind that when a midpoint in an hour has occurred, which is 31 minutes, you can go further. Even though you cannot count time twice, you cannot ignore that these codes are multiple units. So critical that you put down 96118 and then put down the number of units, that is hourly units, where you provided the service. One question that's come up, and this is very, very new, is what can be billed for non-face-to-face time. So whenever you're not doing face-to-face, what are things that you could do? So here's a list of things, including communication with others, medication management, caregiver education, advocating for services, developing and maintaining a comprehensive care plan. So there's a lot of activity that one can bill for that is not face-to-face, involving any kind of diagnostic work. And just to help you define time more clearly, 1 unit is less than 31 minutes, more than 31 minutes, or I should be real clear, equal to or exceeding 31 minutes, but less than 91. And you can see 2, 3, 4, and so forth. Quantify up or down to the nearest increment, and keep in mind that time does not include the patient's activity, waiting for the patient, typing of reports and so forth, so on, but especially by others. This is not clerical. This is what you do. Some suggestions might be to consider the dates and total time elapsed, or if you want to, start and stop times. We do that, but only on the testing face sheet. We do not put it on the report. And consider having a backup, including a scheduling system, a testing sheet. This is recommended to me a long time ago by Christy Jones here in Wilmington, North Carolina. A great idea to have multiple sources of backup. What are some potential limitations? I'm not entirely sure that I can tell you, but I can tell you that maybe interview could go up to 3-4 units, and the testing by the professional could be 10 hours, and the technical could be 8, and the computerized, as I've said before, is a non-time singular event. What about students as technicians? Well, Medicare does not reimburse for student training of any health discipline, largely because they're assuming that we're getting paid by GME. However, it's important that you appreciate that this only applies to Medicare. And students from other universities that are not basically your student, not being trained by you, that they are, for all practical purposes, not students. In fact, if they're students and you're not necessarily having any supervisory activity, they can perform testing for you. Now, here's an interesting idea. Could you consider testing and using students as technicians for Medicare? Well, I do. And the reason is because I have not seen 1 cent from GME. I am being placed in double jeopardy. I also don't have any problems being sued or being audited by Medicare. But do consider that student activity involves only Medicare and involves the students that you're supervising or training directly. This comes from the CPT, and it tells you in detail why is it that you can and cannot use students. If you do have a technician, student or not, the level of supervision that's acceptable according to CMS is general, furnished under the overall direction control. Presence is not required. Presence is not required. Now that I've told you how to use all these codes, I have some bad news. CMS has indicated that we are a misvalued service. Why is that? Because every 5 years they take a look and we have billed more than $10 million. So that's been labeled as misvalued. What does that mean? We've got to go back to the drawing board. Realizing that it is not misvalued, it is actually highly utilized, we have a different problem in our hands. And how is it that we convince these folks that it's not misvaluation, but high utilization? So with that in mind, I believe that we're going to see a redoing of the testing codes probably next year. If you want more information about CPT or anything involving AMA, consider checking out their website or call and get a CPT code book for yourself. Here's the number. If you want information regarding the APA, check out Catherine Nordel and consider supporting the Association for the Advancement of Psychology. And let me go back to APA. Please, please join APA. And in addition to joining APA, make sure you pay your practice assessment. This is what supports all of this work, at least the work of Randy Phelps and Neil Pliskett. And finally, if you want more information, there are several websites. I encourage you to take a look at the psychology coding one, which has information about CPT, the very extended slide set, which includes 600 slides, the ICD code activity, which is about 200 slides, and some sample forms as well. You can contact me, and these are some ways to do so. And with that, we are now going to stop sharing, and we are going to go to questions. Give me a few moments to, let's see here. I need to do a couple of steps. And here we are. We're back. So I'll be taking questions now in the upper right-hand corner of your screen. Click the Q&A button. Submit your questions at this time. So let's go here. Okay, so at this point, we don't have any questions. So let me ask one or two myself. What is happening with the new codes? Well, at this point, we don't have codes. APA is studying them, and I don't know when they'll be addressed, but hopefully it'll be sometime in 2016. Here's another question that people have on a regular basis. They say, it doesn't make sense that you have to use 1/6. My insurance company tells me that psychiatric interview is fine. That's not entirely good. However, keep in mind that if you do that, make sure that that's what the insurance company wants you to do, because technically at the national level, the 1.6 is what precedes the 1.8. That is how you establish medical necessity for testing. But as always, if the LCD says don't do that, then by all means don't do that. At this juncture, I think we have no questions. You're welcome to send me any questions individually, but the webinar completion certificate will be posted in the comments section, which is below. The link will be valid for 1 week. Thank you for visiting tonight, and next time that we have something, we'll announce it probably at the beginning of the calendar year, and that will be to address how things are shaken up with ICD. We'll keep you posted as the new events or changes occur within the CPT system. Check the CPT codes from time to time. Thanks a lot. Have a good evening. Appreciate you joining us tonight.